Hello, and thank you for joining us. My name is Marco Lopez, along with my partner, Simi Agustin. Today, I will be presenting our capstone project entitled Automating Cardiff Model Data Capture in Emergency Departments, Ambient Voice and NLP Integration with the Oracle Center FHIR Systems. This work addresses a critical challenge in violence and overdose surveillance by modernizing Cardiff workflows through automation and interoperability. The introduction and background. Violence and overdose incidents in Las Vegas remains above national averages, yet fewer than half the violent injuries are reported to law enforcement. Hospitals are the most reliable source of incident data, but manual entry into electronic health records systems creates a delay and inconsistencies. The Cardiff model provides a proven framework for sharing standardized data between hospitals and public safety partners, but U.S. implementations rely heavily on manual workflows, therefore limiting scalability. Automating the Cardiff model data capture. The goal here is to automate the data capture during nurse-led triage using ambient voice technology and natural language processing. By embedding this process into Oracle Center systems, leveraging FHIR standards, we aim to improve completeness, accuracy, and timeless while reducing clinical burden. This approach supports a real-time violence prevention and strategies along and aligns with control of the Disease Center Cardiff 2025 Modernization Initiative. Project design and work overflow. Prior studies in Las Vegas showed that free text notes rarely contain usable location details. Less than 10% of encounters had geocodable data. The gazetteer augmentation improved recall but introduced false positives. The geospatial models confirmed that timely hospital data could enhance crime prediction, but manual entry delays remain a barrier. These findings underscore the need for structured, automated data capture at triage. Now I'll give you a little project objective and literature review. The objective of this project is to automate Cardiff model field capturing using ambient voice and NLP during nurse-led triage. Prior studies showed that location data in chief complaints was often incomplete or ambiguous, which led to low F1 scores. Our solution is to record triage dialogue, extract the Cardiff fields in real time, and post them as FHIR resources. Expected outcomes include improved data completeness, reduced venue confusion, avoidance of unstructured notes, and lower latency compared to manual workflows. Here is the proposed workflow of ambient voice and NLP integration. Here's how the workflow will operate. It'll start with the nurse-patient conversation during triage, which is captured through ambient audio. That audio is converted into text using automatic speech recognition. Next, then, the NLP will extract the Cardiff fields like injury type, location, weapon, and substance, and normalizes them into FHIR code systems. These structured fields are packaged then as FHIR resources and posted to the Center Millennium through APIs. Finally, the records will go through a quality assurance queue before being shared with public safety partners. This design reduces manual entry and ensures interoperability across systems. Here's a proposed workflow and methods. For this project, we defined 5 key evaluation metrics to measure success. First, completeness tracks the percentage of encounters with all required Cardiff fields, aiming for at least 90%. 2, accuracy measures agreement between NLP extracted fields and human validated reference sets, targeting a Cohen's kappa of 0.80 or higher. 3, timeliness measures how quickly a structured record becomes available after triage with a goal of under 15 minutes. 4, ASR quality is assessed by word error rate under emergency conditions targeting 0.25 or less, ASR being automatic speech recognition. And then fifth, finally, Slot extraction evaluates the F1 score for correctly identifying and mapping Cardiff Field's entities with a target of 0.85 or higher. These benchmarks ensure that the system meets operational standards for real-time reporting. And here we are with the evaluations and the results. The system achieved 91% completeness compared to 83% for manual entry, which is a significant improvement. Accuracy reached a Cohen's kappa of 0.72, indicating substantial agreement between automated and human validated fields. The ASR component delivered a word error rate of 0.21, meeting our target for noisy emergency conditions. Entity extraction performed well with an overall F1 score of 0.85. And finally, the end-to-end latency averaged 12.8 minutes, which is under the 15-minute goal. These results show that automated Cardiff data capture is both feasible and effective under simulated conditions. Now let's take a look at the evaluation metrics and performance. Beyond the quantitative metrics, we also gathered qualitative feedback from different roles in emergency department. 5 themes emerged consistently. 1 was workflow burden, 2 was data completeness, 3 was accuracy, and 4 was error reduction, 5 was timeliness, and 6 were privacy and ethics. Triage nurses and charge nurses also mentioned workflow burden most often, while informicists focused on accuracy and privacy. The public health analyst emphasized timeliness and completeness because these factors drive real-time reporting. So overall, the staff reported minimal disruption and usability ratings above 4 out of 5, which suggests strong acceptance of the proposed workflow. Here we're looking at timeliness and comparison. So let's talk about the system performance. First off, latency averaged about 12.8 minutes from triage to verified Cardiff record, which is well under the 15-minute target for real-time reporting. Second, high throughput capacity was strong, about 101 encounters per hour on hospital-grade hardware, showing that the system can scale from busy emergency departments. Third, completeness improved to 91% compared to the 83% for manual workflows, which means fewer gaps in the critical data. Finally, these results validated the feasibility of automated Cardiff data capture in emergency department settings. Together, these metrics confirm that the system meets operational standards for speed, capacity, and reliability. Okay, so discussion and conclusion. So let's wrap it up, the broader implications. Automating Cardiff data capture reduces clinician workload and accelerates data availability for both public health and law enforcement. Real-time Cardiff data means that hotspot detection can happen within days instead of weeks, which improves resource allocation and prevention strategies. At the same time, ethical safeguards remain essential. Things like patient consent, de-identification, and spatial fuzzing are critical for maintaining trust and compliance. Together, these elements show that automation can strengthen violence prevention while respecting privacy and operational integrity. Now let's take a look at implications and ethical considerations. Implementing ambient voice and NLP in emergency departments has broad implications. First, integration affects hospital workflows, public health reporting, and law enforcement coordination, so governance and interoperability are critical. Second, timely Cardiff data enables proactive prevention strategies, helping communities respond faster to violence and overdose trends. Third, ethical safeguards must remain front and center. Things like informed consent, strong privacy protections, and secure data handling are non-negotiable. Finally, bias monitoring is essential. Continuous audits ensure that speech and language models perform fairly across diverse populations. These considerations make automation strengths public health without compromising trust or equity. And to conclude, this project demonstrated that automating Cardiff data capture with ambient voice and NLP is both feasible and aligned with industry standards. The system meets interoperability requirements through FHIR and CDC guidelines, which is critical for scalability. Looking ahead, the next steps include live hospital pilots, cross-platform validation, and expand the model to cover overdose and self-harm variables. Ultimately, this approach positions hospitals as active nodes in community violence prevention networks, enabling real-time insights that can drive faster, more effective interventions. Thank you.